Good morning to all. Today's topic is on dental implants. So today we are dealing with just the basic principles of dental implants. Coming to the learning outcomes, differentiate peri-implant structure from natural periodontal structures. List two methods of implant placement surgeries. Explain osseointegration. Categorize various treatment possibilities using implants. Coming to the history of dental implants, the history of modern implant industry began with the introduction of titanium implants. So in the 1915, Per-Ingvar Brännmark, a Swedish professor of anatomy, had a serendipitous finding while studying blood circulation in bone. So that became a historical breakthrough in medicine. He discovered an intimate bone-to-implant position with titanium that offered sufficient strength to cope with load transfer. So he called the phenomenon osseointegration and developed an implant system with a specific protocol to predictably achieve it. So these implants were used to anchor prosthetic replacement teeth in the edentulous loop, and the first patient was successfully treated in 1965. So that is the history of dental implants. Coming to what is an implant? It is a biomedical device composed of an inert material or alloy placed on or within the soft tissue. So such implants are used to replace single or multiple teeth or to serve as abutments for fixed or removal processes with the goal of restoring masticatory function or aesthetics. So when we come to different terminologies, we have implant, that is inert material that is inserted into the body, and the fusion of implant to the bone surface, it is called as osseointegration. And success is determined only when osseointegration has occurred, and survival is that when implant is seen in the oral cavity. So coming to the parts of an implant, so we have, you can see with this picture, the parts of an implant. So starting from the apical point, there is the fixture. There is the apical part, there is a fixture, there is implant body that is getting inserted into the bone. And the above part, there is the abutment that for supporting the crown. And then it is getting attached to the implant body with this screw that is called cover screw. And then coming the crown part which is seen outside. So this is the crown part. So these are the parts of an implant. So this cover screw can be called as either a cover screw or implant obturator. Okay. So in this two-stage implant, this will be placed to prevent soft tissue and bone from invading the abutment connection area during healing. So whereas we have a healing abutment also over this. So if it is a non-submerged type, we used to give the healing abutment. So it will come over it. Okay. So that is to heal or shape the gingival tissues after uncover procedures for the future implant placement. So whereas this abutment, there is a portion that serves to support or retain the processes. So it can be of different types. It can be of screw type, cement type, or attachment device. Okay. So coming to different parts of abutment. So now we studied what is an abutment. So there is a portion of implant that supports and retains a processes or implant superstructure. So there are different types of abutments. So there is the different types. There is according to the shape. There is we can have straight abutment and angled abutment. So what do you mean by straight abutment? That is, you can see in the picture that it will be straight, and this will be indicated for replacing single tooth for large processes up to full arch. Implant bone reconstructions. So this can be used for replacing single tooth as well as for the large processes up to full arch. Implant bone reconstruction used only when emergence profile are parallel. So if the emergence profile is parallel, you can go for the straight abutment. The disadvantages with is that cannot be used in angled profile, whereas this angled abutment, this is available in angulation. See, you can see that it is angulated. Mainly it is used for anteriors. So it is improved aesthetics to correct path of insertion can be achieved. Increase in angulation, increase in angle. The disadvantage is that increased risk of fracture placed, and it places deeply as possible with most favorable axial orientation. So coming to the, depending on the retention, it has been classified into abutment for screw retention. There is a screw retain. You can see that it is getting attached to the abutment through screw. And this is a cement retain, is the same like how the crown has been cemented over the tooth surface. That is, you can see that this abutment will get screwed into the implant body and then this will be cemented over the abutment. And we have attachment type of retention is available, and depending upon the design we have flat topped abutment, tapered shouldered abutment, and direct gold copings. So coming to the differences between, there is the cement retained, there is advantages and disadvantages we are going to deal with. There is, what are the advantages? There is better passivity, easier to obtain aesthetics, fewer porcelain fractures, less fatigue, manipulation easier, loosening less often compared to that of screws. Occlusal surfaces remain intact as there are no screw holes, so better axial loading. So disadvantages are difficult to retrieve unless soft cements are used. Abutments sometimes must be prepared intraorally, and gingival retraction may be needed when permanent cements are used. Evaluation maintenance of implants is difficult. Increase in the momentum of force. So coming to the screw retained type, advantages are low profile of retention, less momentum of force, no risk of cement in the sulcus, easily retrievable. Whereas the advantages are loosening of the screws can be difficult to obtain passivity, difficult to obtain aesthetics, greater chances of porcelain fracture, and access in posterior regions will be difficult, and risk of aspiration. Then we have attachment, abutment for attachment. So this type, there is a ball type and a joint type. You can see that it is uses an attachment device to retain a removable processes. So we have mesostructure bars. It can be continuous or non-continuous, and also superstructure attachments like magnets, custom clips, and header clips. So this is the picture showing the abutments. There is with the attachments, you can see that bolts for attachment o-rings. So this is with the o-rings attachment abutment, so it can be fixed. There is the processes. So this will be the underside of the denture. Then we have this bar clip type. So this is clip is attached inside the processes and it will be locked into the area. So this bar is fixed to the implants and jaw. So this is the implant that is attached to the through the bar. So coming to the healing part, that is the osseointegration. So this is important. So what do you mean by osseointegration? So this is what we need to achieve after the implant placement. So this determines the stability and the success of implant placement. So osseointegration is defined as a direct contact between living bone and a functionally loaded implant surface without interpose of tissue at the light microscopic level. So there are different factors that determine the success of or the osseointegration formation. There is the stage of implantation is important, and surgical considerations are important, and loading conditions are important. So coming to the implant area, there is implant design is important, implant material is important, implant surface. So all these factors play an important role in the osseointegration. So clinically, osseointegration is the asymptomatic rigid fixation of an alloplastic material in bone with the ability to withstand occlusal forces. So there are different stages for its formation, starting with the incorporation of woven bone formation, an adaptation of bone mass to load, or lamellar or parallel fibered deposition will be there, and then adaptation of bone structure to load is there, bone remodeling will be there. So these are the three stages, different stages of implants. There is incorporation of woven bone formation, there will be adaptation of this bone mass to load, that is by the formation of lamellar and parallel fibered bone deposition. Then there will be adaptation of bone structure to load, that is bone remodeling. So coming to the difference between natural tooth and implant. So with the picture itself is very clear that you know that this here it is the periodontal ligament fibers are attached to the cementum, and we have the junctional epithelium of 0.97 mm and connective tissue attachment of 1.07 mm, and the biological width is known to be 2.04 mm. Whereas the implant, you can see that there is no tooth surface, cementum is not there, periodontal ligament fibers are not there. So this bone is directly getting attached to the implant surface without incorporation of soft tissue. So that is what osseointegration is. And also you can see that the fibers are parallel to the gingival, to the implant surface, whereas here it is perpendicular, somewhat it is perpendicular to the surface. So here it is more like parallel. So it which enables the penetration of probe through the probe very easily. And also you can see that increased amount of junctional epithelium, which is like more permeable as compared to the tooth surface. So there is junctional epithelium and connective tissue attachment will be more, and the biological width is more in case of implant. So coming to the details of each, there is peridental tissue and peri-implant tissue. So free gingival margin with buccal keratinized epithelium. So both the areas there will be there, and gingival sulcus apically limited by junctional epithelium. It is same in both the cases. Keratinized epithelium at the base of the gingival sulcus, whereas no keratinized epithelium at the base of the gingival sulcus. And you can see that junctional epithelium adherent, less permeable, high regenerative capacity in around the tooth surface, whereas here in implant it is a poorly adherent, more permeable and low regenerative capacity. And whereas here periodontal tissue we can see cementum, and here obviously there will not be any cementum, and here the gingival fibers will be running perpendicular to the tooth surface, and here it will be, so there is an error, gingival fibers running perpendicular to the tooth surface and to the bone, where here gingival fibers running parallel to the implant collar, and biological width of at least 2.04 mm, and here it is biological width of 2.5 mm. And the periodontal ligament will be seen, no periodontal ligament, no direct contact between tooth and bone. Here it will be direct contact of implant to bone. So when we tell about the details with the difference between the natural tooth and the implant, you can just define it according to the structure. There is a connection wise, junctional epithelium and connective tissue, biological width, vascularity, probing depth, and bleeding on probing. Okay, so bleeding on probing, I want to tell that it is will be more reliable in case of tooth surface, whereas the other thing implant surface it will be less reliable. Okay, and the probing depth also we have to make sure that this in health it will be 3 mm in case of tooth, and whereas for implant it will be 2.5 to 5 mm. Okay, so that is there, and we move on to the next slide. So now coming to the classification of implants. Okay, so we will be classifying based on different categories. The first one according to anatomical position. It is being classified into endosseous implants. Endosseous implants means it is placed, the implants that are placed directly into the socket, which is prepared by using a series of specially prepared drills. So it can be screws, cylinders, blades, pins, rammers or frame. You can see that it can be of different types, blade, cylinder type, and screw type. So mostly we will be using screw type now, and endosseous implants also. So coming to the subperiosteal implants. So what is subperiosteal implants? You can see that it is a custom fabricated framework of metal that is supraalveolar, that is will be on the top of the bone. It will not be inserted into the bone, so it will be on the top of the bone. So impression will be taken, will be customized, and will be prepared like this, and this you can see that posts remain above gum tissue as angles for replacement teeth, and this gum will be covering the framework, and only this will be seen, post will be seen outside. Okay, so it can be complete arch implants, two piece implants, one piece unilateral implants. Okay, so then coming to the type, that is a transosseous implants. So there is a non-osseo-integrated staple implant type which are used in mandibular anterior type. So this is not based on the concept of osseo-integration. So this will be like stapler type. So there is a post pass through the jawbone. You can see there is a gum covers the post, and you can see that the under surface there is a plate that joins the post together. So there is a lower jaw bone. So there is the stapler type. So this gum tissue that will be covering the post. So these like metal plate that joins the post together. There is a transosseous implants. So it can be single pin staples and multiple pin staples. So all these, some of these implant systems were initially were stable and appeared to be successful over short time periods, but failed to remain stable. So that became symptomatic or loose and failed over longer periods. So lacking the predictability, these implant systems are not used. So currently, and mostly endosseous implants have a cylinder or tapered screw type threaded design are used nowadays. So coming to the according to the shape of implants, it has been classified. There is a macro design type. We have threaded type, threadless type, blade type, open measure frame, and button type. So according to the surface characteristics, there is the micro design. We have additive surfaces and separative surfaces. There is we have polishing, machined, grid blasted, etched, and coated. According to the material used, we have metals, ceramics, and polymers. So, metals we have titanium, that is commercially pure titanium. We have ceramics, for example, hydroxyapatite, zirconia. Polymers we have polytetrafluoroethylene, polymethacrylate, polyurethane, etc. According to the implant tissue interface, there is osseointegration and integration can be, but we are expecting to have osseointegration. You can see that osseointegration, the titanium will be directly connected to the bone. So whereas there will be infused growth of conti tissue over the bone surface, so there is a fibro-osseous integration. So this usually when this fibro-osseous integration, if it happens, it may lead to implant failure. According to the biodynamic activity, we have biotolerant type, bioinert, bioactive. According to the mode of retention, implant support removal processes, implant supported fixed processes. So, what are the indications of implants? We have what are the indications? There is you know that it can be replaced. There is a single of multiple missing tooth replacement, partially dangerous patients with free and dangerous area. Preventive implant is indicated following extractions to retard the ridge or resorption, macroglossia or hypermobility of tongue, and intolerance to bulky complete denture, and patients' desire for a stable processes and for orthodontic anchorage. Contraindications are local or systemic diseases which would jeopardize healing, for example, uncontrolled diabetes, blood dysplasias, cardiac diseases, cancer, AIDS, etc. Patients who are not motivated to maintain acceptable level of oral hygiene and those who are having poor bone quality, if insufficient interarch distance in the dental space or lack of access for instrumentation, sensitivity to specific implant components, history of smoking dependency, and psychiatric disorders. What are the advantages? Obviously, there will be maintenance of bond, maintenance of occlusal vertical dimension, improved psychological health, increased retention and stability, tooth positioned for aesthetics, improved phonetics, increased survival time of restoration. Coming to the disadvantages, obviously there will be expensive. It is compared to the other treatment, it is very expensive and long treatment duration is needed. And repeated recalls are always necessary for the longevity of implant success and anatomical limitations in placement. So pre-surgical evaluation. So when you are planned for implant placement, so you need to go for pre-surgical evaluation in various aspects like restorative requirements. So you have to see for the restorative requirements whether they are meeting with the requirements. And interarch space is important. That is, minimum space should be there for the implant placement. There should be 1.5 mm distance from the both from each side, that is from the adjacent tooth there should be 1.5 mm. If it is two implants are placed together, there should be 3 mm distance between two implants. And also there should be location of edentulous area you have to see, and the bone quality and quantity should be assessed by radiograph, OPG, IOPA, lateral surf, CT, CBCT. So the all can help you to find out the proper evaluation of the surgical area. So the bone quality is very important for the placement of implants. There is available bone height, available bone width, available bone length, available bone angulation, and the crown implant body ratio. So coming to the bone density, this one classification has been given by the mesh. This is very important for evaluating the bone quality. You can see that D1 there is a dense cortical like mimicking the oak or maple wood that is seen in anterior mandible, whereas D2 there is a porous cortical and coarse trabecular seen in anterior mandible, posterior mandible and anterior maxilla, whereas D3 there is, you can see that it is a porous cortical, there is a thin and there is a fine trabecular area, and D4 will be fine trabecular. So you can see that D1 is very dense cortical and here it is porous cortical with coarse trabecular and porous cortical with fine trabecular and this fine trabecular. So this is very D5. One more quality is that is for immature and non-mineralized bone. So you can see that the areas of jaw there is exhibiting thin layers of cortical bone and larger cancellous space such as the posterior maxilla especially. You can see that have lower success rates than areas of dense bone. So ideally speaking, D2 and D3 are ideal for implant placement, and D1 is more dense cortical, so the blood supply will be less, and also it can lead to increased heat generation and can lead to necrosis. So whereas D2 and D3 are ideal for implant placement. So this whereas D4 and D5, D5 is broadly not indicator for implant placement, whereas D4 in posterior maxilla they have lower success rates than areas of dense bone. So always the best results are achieved when the bone to implant contact is intimate at time of implant placement. Coming to the surgical anatomy landmarks and limitation, there is also important after surgical evaluation, you have to see for the anatomical landmarks. You can see that floor of sinus and nasal cavities, incisive nerve, inferior alveolar nerve, and roots and apices of the neighboring teeth and top of the alveolar crest. So coming to the different parts of implants, so we have the kit with us. So and this will be different. The names will be different in different systems. Okay, and there will be slight variations in the parts also in varying systems. So here we have tissue level from the wrench we have or ratchet. It can be called as ratchet for the placement of implants, and we have the depth gauges or paneling pins. That is to measure the depth of the implants and to probe the osteotomy site. And you can see the tissue level hex drill and hex tool, and bone level hex drill and hex tool. Abutments, there is drill and tool is there, and drill extensions are there. Tissue punch, there is for flapless implant surgery, and this is the pilot drill or Vansel drill. There is a first drill, and there's a countersink drill is there for the shoulder part, and we have the locator drill. And you can see that the twist drill is of varying width diameters, that is with the 2 2.5 3 3.5 3.7. So usually for the 5.5 width implant we will just drill till 4.5, so just 1 mm lesser than the actual width of the implants. So we have paneling pins also to find out the parallelism and for the depth of the implants. And we have tab drill. Tab drill will be given for like high quality bone quality areas. That is the D1 and D2. You can go for tab drill will be there, and we have depth spokes. So coming to the processes, screw is there, that is for retaining the abutments, and we have the copying. So there is the thin covering to the implant abutment and serves the connection between implant and prosthesis. And we have analog that is used in the fabrication of master cast to replicate the retention portion of the implant or abutment. Okay, then we have the transfer copy that is used to position an analog in an impression. It can be direct or indirect is there. Hygienic screw is there. We have abutment for screw retention, cement retention, and for attachment. Then we have second stage for mucosal extension or healing abutment. And first stage cover screw is there and the implant body. So coming to the surgical procedure, details of the surgical procedure, we have first surgical phase, there is implant placement under local anesthesia. Then this places in the implants into the jawbone with a very precise surgical procedure. The implant remains covered by the gum tissue when fusing into the jawbone. So this is telling about the submerged type of implant placement. So we will be discussing on flapless implants, submerged implants, and non-submerged implants. Okay, and for submerged implants, always we have to go for the second surgical phase. There is implant uncovery. After approximately 6 months of healing under local anesthetic, the implant root is exposed, and a healing post is placed over top of it, and the gum tissue heals around the post. And the next phase is the prosthetic phase. There is a once the gums have healed, an implant crown is fabricated and screwed down into the implant. So you can see this diagrammatic representation. Implant is inserted into the bone and healing process of the bone. You can see that the integration has been achieved. This is submerged type, and you can see that this is the second stage uncovery. Implant uncovery, and the dental implant is placed on the dental implants, and it has gone for the crown placement. So implant placement, as we told before, there are several types of implant placements. So here we are only dealing with the main important one, that is a submerged and non-submerged mainly, and with the flapless type of implants also. So the one stage that is the non-submerged implants, that is there is no need of second surgery, especially there is the gingival former will be placed above the tissue. This will be seen above the tissue. There is a coronal portion of implant extend to gingiva. So that is the non-submerged type, and we have submerged type. This will be at the bone level, so top of the implant completely submerged under the gingiva. So you can see the. So coming to two stage and one stage. Two stage implant heals under the soft tissue, and is after healing period. It is accessed through a second stage surgery. And one stage is the implant heals without the protection of oral mucosa and is accessible through the mucosa during healing. Okay. So there is two-stage approach usually indicated when there is extensive bone loss at the implant site. So usually there is, if there is any ridge augmentation is needed, or if there is any bone loss, bone defect nearby, there is at the implant site, then you can go for two-stage surgical approach to clearly visualize the area, and it will not interfere with the healing process. That is, it can be completely submerged under the bone. So when this vertical bone augmentation is necessary on bone quality is poor. Whereas one stage surgical approach, mucogingival management around the implant will be easier, so that the soft tissue contouring will be easy for it, because the gingival former will be given at the first stage itself, so it can clearly heal with the gingival side also, other than osseointegration. So patient comfort increases because fewer surgeries are involved, and aesthetic management is. So here it comes the one stage surgery. So first the pre-surgical evaluation, examination, treatment planning. So here comes the fixer placement, there is the implant placement, and here the waiting period for the osseointegration. It will take 3 to 6 months. It will vary according to the quality of bone and the host response. And the fabrication of the final restoration will be there after removing the gingival former and delivery. The radiographic examination will be taken, and oral hygiene instructions will be given, and there will be regular checkups. To two-stage surgery, the same way there is examination, treatment planning, and the fixture placement, and the 3 to 6 months. Here, this will be completely submerged. We will be covering it. It will not be seen outside. So the second stage surgery after 3 to 6 months, if we will make sure with the radiograph that there is adequate amount of bone, and there is osseointegration has been achieved, and we will go for second stage surgery, that is uncovering the area, and if there is any soft tissue or bone placement over the cover screw, it has to be removed. And then we will keep gingival former, and within 7 to 10 days we expect to have a gingival formation around the implant area, so which mimics the natural papilla, which mimics the normal tooth papilla. So then we will go for the final fabrication of restoration, and then the delivery. The same way radiographic examination is needed after it, all hygiene extensions will be given, and the regular checkups are needed. Basic principles of implant therapy to achieve osseointegration. So this is very important. We need to know what are the principles needed for osseointegration. So this osseointegration determines the success of implant placement. So implants must be sterile and made up of a biocompatible material. Example, titanium. Titanium is more superior to other materials. Implant site should be prepared under sterile conditions. Implant site should be prepared with an atraumatic surgical technique that avoids overheating of the bone during preparation of the recipient site. So atraumatic surgical technique, and also you should avoid overheating. There is a pumping action. When you drill the area, you have to move up and down, and also it should be irrigated with cool saline. Implants should be placed with good initial stability. So the initial stability is very important. Primary stability should be achieved during the placement, at the time of placement. So implants should be allowed to heal without loading or micro movement. That is, undisturbed healing period is needed for 2 to 4 or 4 to 6 months, depending on the bone density, maturation, and implant stability. So coming to the surgical part, incision. The type of incision and the extent of flap elevation depend on several factors. So according to the width of attached gingiva, keratinized tissue, ridge form, presence of undercut, or any simultaneous grafting procedure to be done, etc. It is used as a mid-crustal incision is given with or without vertical incision. So if you want to go for bone graft placement and all, always there should be vertical incisions along with the mid-crustal incision. So here we will be giving mid-crustal incision and with or without vertical incision, and the flap is elevated to expose crustal, facial, and lingual parts of the bony ridge. So you can see that the most common is crustal flap design. So bisecting the existing zone of keratinized tissue, the attached gingiva at the ridge crest should be evaluated if you are going for a mid-crustal incision. So if the implant site has an adequate buccolingual band of keratinized tissue, then incision can be made as to bisect the keratinized soft tissue. So which results in a minimum of 2 to 3 mm keratinized soft tissue on both labial as well as lingual side of the implant. So, for example, if the implant site has not adequate keratinized band, the incision uh, should be made as to bisect thin keratinized tissue band, and the implants are placed, and soft tissue grafting should be performed. Okay, and if papilla are intact on the implant site, then the papillary incision should be preferred to maintain papillary height to achieve better soft tissue aesthetic. So always we have to evaluate the soft tissue area before we are going for the incisions. Okay. So here we are going to prepare the gingiva with the gingival punch, or so that is what by evaluating the bone level and the tissue, we have to decide whether we have to go for submerged type of implant, non-submerged type of implants, or for the tissue punch type. Okay. Then coming to the flap elevation. So facial and lingual mucoperiostal flaps should be elevated to expose the ridge crest as well as the facial and lingual ridge of the ridge. So by flap elevation, if we are not going for flapless implant placement, we will be going for the flap placement. So we will be clearly evaluating the bone morphology by reflecting the flap. So you can see that here we have elevated the flaps. So for the better visualization, either you can go for the retraction, and also you can go for the suturing. This elevator flaps can be sutured to the buccal mucosa or the opposing tooth to keep the surgical site open during the surgery. So the bone at the implant site must be thoroughly debrided of all the granulation tissue. Okay, so that is important. And coming to the next, there is a pilo drilling. So there is the initial drill. So it can be called as lance drill or locator drill or anything can be. Okay, so it will be just 2 mm wet, and so that will be drilling to the depth. So there is the initial drill, initial point it will be. After exposing the underlying bony ridge, either a surgical stent on the site or the reference of the adjacent teeth is taken to prepare the implant osteotomy. So the surgical stent can be used. If you are a beginner with implant placement, you can always depend on surgical stents. So which will be three-dimensionally correct for the future processes. A sharp pointed lance drill or pilot drill is used to make an initial entry into the bone. Alternatively, a small round burr can be used to mark the implant site and to drill through the high density prestal bone. So the drilling, pilot drill to final must be done under a constant stream of chilled saline. So you can see that this is the marking drill that is with the lance drill or pilot drill or location drill. So it is called as it is just 2 mm width, and it should be just knife edge type contouring or flatten of bone can be done if you are before going for the implant ditch, the initial ditch. You can go for contouring the alveolar bone. So there is, if it is very knife edge, you can go for contouring or flattening. So then you will be continuing with a series of drills. So you can see that after the initial drill, then you will be going with a series of drills that are used to prepare the osteotomy site precisely and incrementally from an implant. So you can see that it will be available with varying depths. Okay. So it will be like it will be differentiating with a different color codes also. So that is also different in different systems. Okay. So this will be drilled with the RPM, that is the like 800 to 1200 till 2500 RPM also, depending on the bone density, and a constant stream of chilled saline. Okay, always there will be a pumping motion, that is upwards and downwards motion is important to avoid overheating and necrosis. Okay, so coming to the depth drilling, there is a pilot drill or depth drill which usually remain 2 mm of diameter. First used to partial depth and direction of drilling is three-dimensionally evaluated by inserting a parallel pin or force direction indicator in the partially prepared osteotomy. Always after the initial preparation, we won't be reaching till the depth, to the final depth. Okay, after the initial drill, you have to place your parallel pin and you can take the radiograph. So the parallel pin always it will be engaged with the flow so that it will not be swallowed, or it will not be misplaced during or take during the radiograph. So that is the pin force. If the direction is correct, then we will continue with the depth drill is further used to complete the depth, and all the planned osteotomy depth should be attained by pilot drill itself, as the rest of the drills are only used to widen the osteotomy. Okay. For example, if a 13 mm long implant is planned, depth drill should attain 13 mm depth first. Okay, so first the half drill will be given, and then we will be evaluating it by taking radiograph with the parallel pin, and then we will be continuing till the 13 depth, and then only we will go for the widening. Okay, so to widening of the osteotomy drills. Okay, so a surgical guide is always help you to find out there is a check for proper positioning and nose throughout the procedure to direct the proper implant placement. Okay, so after taking the initial ditch, if you are seeing that it is just misplaced or just it is not in the correct direction, you can use like a Linman drill or lateral cutting drill, Linderman drill or lateral cutting drill. For there is will be 2 mm diameter that will that side cutting drill can be used to redirect to the correct positions. Okay, so then coming so after reaching to the desired depth, depth gauge will be used to evaluate the preparation depth with respect to bone increments or anything trapped inside. So to check the osteotomy side, we will be using the depth gauge. Okay, so after this will be moved on to the osteotomy widening. That is after pilot drilling to the planned depth, the osteotomy widening drills will be done. They are sequentially arranged used to get the same depth. Okay, a series of different diameter of osteotomy binding drills are available in case of 2.8, 3.2, 3.65, etc. So they are used to get the desired depth depending on the diameter of the implant. It will not be exactly same as that of the diameter of the implant. For example, depending on the bone density, it will change. The diameter of final drill will be zero point 0.3 to zero point 0.8 mm less than the diameter of the implant. For example, if the planned implant is width is 5 mm, so the final the diameter of the final drill must be approximately 4.2 mm. Okay, so whereas in case that will be in the case of D3 or D2 quality, whereas in D1 quality of bone it will be just approximately 5 mm. Okay, it will be more near to, for example, either it can be 5 mm diameter can be widened or 4.7 mm, it will more. For D3 D4 it will be lesser. Okay, it will not be reaching that exact diameter of the implant. Okay, so that is first one. We will be doing the pre-drilling area with 2.8 mm. Then with the varying, there is extension drilling will be given. There is with the sequential order 3.1, 3.25. So extension drilling will be done to nearing to the width of the implant. Then we will be giving the smart drill. That is for a smart drill behavior. So all the time you have to be careful. That is while drilling, there should be like pumped out or pulled out the osteotomy side while drilling to exhaust them to the water coolant and to facilitate this clearing the bone debris from the cutting surfaces. Okay. So coming to the crestal drill, there is the drilling depth depends on the bone quality. So if it is D1, D2 quality, we have to make a crestal drill that is with the maximum 650 RPM. You can see that with the cortical bone will be giving that as the upper area, that is a D1, D2, D3, D4. You need only this much. So that is for making the crestal drill at the implant shoulder area. So then coming to the bone tapping. So usually this bone tapping that is basically making the screws. The serrations will be created inside the osteotomy site. So this will be done in case of D1, D2. The bone tap can be used manually as well as machine driven also. So for bone tapping, the RPM will be reduced to 35 RPM. So you can see that this is the osteotomy site created after bone tapping. So then coming to the implant insertion part, there is an implant is inserted, carried to the prepared osteotomy and screwed in with clockwise rotations at a very slow speed, that is 25 to 30 RPM, using a rotary handpiece or hand ratchet or wrench. Okay. So coming to the implant insertion, there is implants are inserted with a handpiece rotating at very slow speed. There is a 25 to 35 RPM. So you can see that this is a handpiece and or it can be used by hand with a wrench. So insertion of implant must follow the same path or line as the osteotomy site. You can see that the outer non-sterile covering should be opened by the assistant without touching the inner sterile wire, so which contains the implant and the implant screw. You can see that it will be carried to the side by the hand ratchet. So here it is the hand ratchet. It will be attached to the hex drive, and this will be taken with the implant, and this will be carried to the side by the ratchet. So you can see that if it feels very greater resistance to rotate it to very greater resistance to insert, you can rotate it to counterclockwise to unscrew the 2 to 3 threads of implant. So without too much force, with 25 to 35 RPM, it can be inserted into the implant site. You can see that. So the next area, you can see that this thread should be completely inserted into the bone. It should not be exposed. So this upper implant shoulder should be seated at the bone surface if it is submerged implant. Otherwise, this can be for the non-submerged implants, the healing, the implant shoulder will be a little more at the higher level. Okay, you can see that this is the submerged type of implant. So this is at the implant at the bony margin. You can see that this implant has been placed. The next stage of submerged implant will be the placement of cover screw. You can see that this will be inserted with very limited force. There is 15 n centimeter. There is the implant should be closed using the covered screw, and that is mainly to avoid entrapping the food particles into the implant body area. Okay, then you can see that this flap has been approximated and then sutured. So you can see that then coming to, okay, there is a time period, the waiting time period of 4 to 6 months. After that, you will move on to the second stage surgery. So you can see that this small incision will be given for uncovering the area. So the main objectives of second stage surgery, that is to expose the implant, submerge implant without damaging the surrounding bone, to control the thickness of soft tissue surrounding the implant, to preserve or create attached keratinized tissue around the implant, to facilitate oral hygiene, to ensure proper abutment seating, to preserve soft tissue aesthetics. So you can see that after the removal of cover screw, you can give the gingival former. So this is the gingival former or shaper is being placed, and you can see that after the healing period of 7 to 10 days, removing the gingival former and will be, so you can see that this is the implant shoulder area. That is, you have to make sure that before going for the gingival former, the covered screw, if it is covered with the bone or soft tissue, it has to be removed. Okay, before placing the gingival former. And you can see that this will control the exposure of implant shoulder. There should be no reaming softer hard tissues around the implant platform. Then you can go to the transfer abutment. There is the insert the transfer abutment. Feel free of choosing an impression with the open tray technique or closed tray technique. So the details of prosthetic part will be discussed in prosto department. So coming to the impression part, you can see that placement of transfer cap and begin syringing the preparation. You can see that the light body material is being injected to the area. So at the same time, the assistant should load the tray with the impression material. So you can see that the seating the tray as soon as you have finished the loading of impression material. And after oral placement, ensure that no pulls or drags and a good lamination of the material to the surrounding area. So coming to the tray removal, you can see that after the mouth removal of the tray, control the right positioning of the transfer cap. So coming to the laboratory procedures, remove the transfer abutment and place it in the right position of the impression tray. Then insert the gingiva shaper and send the impression tray to the laboratory. So we have taken back the transfer, there is the abutment analog, and you can see that we have given the gingival former. So next to the abutment insertion, there is the after the finalized fabrication of the crown, insert the pre-milled abutment. So abutment is being placed and screwed with a cover screw and the cover crown placement. There is a prosthetic restoration has been done. This is cement retained crown. So coming to some of the clinical photographs of submerged different types of implant placement. First one is submerged implant. You can see that here the midcrustal incision has been given. Flaps have been elevated to the buccal and the lingual. You are able to see the osteotomy site. There is a bone level. So if it is very knife edge, you can do for contouring or flattening of bone with a large round burr. Okay, so then we are moving on to the series of drills are used to prepare the osteotomy site precisely. You can see that with the varying sizes, we will be reaching to the desired depth, and then we will be using different drills for widening the area. And then implant has been placed. You can see that it is more submerged type of implant. So then soft tissue will be covering it with the sutures. Then Copac has been given, and this is the post-operative view after the crown placement. So for this non-submerged implant, the same way metatarsal incision has been given, and then after the lancer drill, the pilot drills have been given with varying depths. So after reaching the desired depth, the various osteotomy sites will be extended with a different pre-drills, extension drills to reach the desired width of the implants, and then implant has been placed. So you can see that it has been taken with the ratchet, and it will be carried out to the osteotomy site, and it will be inserted into the implant at a very slow speed along with the irrigation. And this is the non-submerged implant. You can see that implant shoulder has been placed at the bone level. It will be emerging to the soft tissue, and then gingival former has been given. Long gingival former will be given for non-submerged implant. So this is a post-operative view. So coming to the different type of implants, so coming to the third type, there is a flapless type of implant. So we have already discussed in the while discussing the parts of implant, we have discussed with the tissue punch. You can see that stent has been placed, and this is the tissue punch that is being attached to the handpiece, rotary handpiece, and this punch has been given, and this soft tissue has been removed. So this is the post view that is after the tissue punch, that is you can see the site. So this will be clearly seen with the bone level. So you can start doing the sequential procedures, that is the first one lancet drill and the pilot drill to the desired depth, and then the widening of the um, osteotomy site, and then the implant placement. And the same way, like non-submerged implant, the gingival former will be given, and we'll be waiting for another sequential period of time for osseointegration to happen. So that is about flapless implant. So coming to the successful dental implants, what are the factors that are important? It should be immobile, it should be absolute dimensions, gingival health, bone loss should be less with 2.2 mm, functional, it should be functional, radio opaque is important, and biocompatible and void of pain and infection. So that's all for successful dental implant, and that's all for today. Thank you.